My name is Peter Orris. I'm from the faculty at the University of Illinois here. I have the pleasure of facilitating this interaction. But I think we're at 117 and I'm told we have 250. So I'm going to wait just a moment while everybody clicks in.
Peter, we'd like to proceed to the translation slides before you do your little welcome.
Okay. Then what, shall we do them now? We've got 143 on there.
Yes, let's move forward, please. Thank you.
We'll begin with an instructions on the interpretation.
Hello. We're going to be having Spanish and English interpretation today. So everybody should be choosing a channel by going to the bottom of your screen if you are on a computer and click on the globe button and then choose the channel that you want to listen to, whether it's English or Spanish. Buenos días, vamos a tener interpretación el día de hoy.
Good morning. We're going to have interpretation today. If you're in a computer, go to the bottom part of your screen and click on the button where of the language you want to listen to. If you're on a phone,
on the three dots, then go to language interpretation and then select the channel that you want to listen to. And then it's very important that you also click done. Si están en un teléfono celular o en una tableta, por favor.
If you're on a cell phone or a tablet, please go to the bottom right and click on the three little dots, then select the menu where it says a language interpretation and select the channel that you would like to listen to. And something that is important is at the top right, there is a sign that says done. You have to click on that to be able to activate the feature. Thank you.
So as I started, my name is Peter Orris. I'm from the faculty at the University of Illinois School of Public Health. And we are really excited with this webinar today. It was coordinated by the global program here and continues the interactions between the School of Public Health here and the Cuban School of Public Health. Despite the prestige of the participants today, we're not going to spend a long time introducing everybody with their academic credentials and others. We'll give you brief introductions, which will help the participants in the webinar understand how you are viewing the current situation in the last 2 years in both Havana and Chicago. So let me begin by turning this over to Dr. Wayne Giles, who's the dean here at the University of Illinois School of Public Health.
In the state of Illinois. And I don't think anyone realized back then sort of that 2 years later, we would still be wrestling with the pandemic. But I think it goes to show the strength and the importance and the value and dedication of the public health leaders around the globe. And I do want to take a minute to pause and just thank them for their hard work and dedication, because these have been very trying times. I do want to say we're extremely thrilled to be co-sponsoring today's webinar with our partners in Cuba at the National School of Public Health, NSAP, in Havana, and along with our partners at Medic Review as well. In 2015, the UIC School of Public Health and NSAP signed a memorandum of understanding to establish a partnership between the two schools that includes an exchange of students and faculty, as well as joint research endeavors and a number of collaborative efforts, including the work that's going on here today. I do want to mention that there were a few people who were present at the signing of that agreement, including Dr. Peter Orris, who you just met, Pastor Carlos Flores, the director of NSAP, who you'll hear from in just a few minutes, Professor Tanya Aguilar-Guerra of NSAP, who was part of the planning team as well. Other activities that are part of this partnership include hosting Cuban faculty members here on campus at UIC, including Dr. Pedro Mora, who will be presenting today, and NSAP hosting a number of our MPH, Masters of Public Health students for our summer course in Cuba as well. Throughout this partnership, Ms. Gail Reed and the Medic Review have been really important collaborative partners in this work as well. Oh, I guess I need to click on something. Let me do that. Okay. We are also grateful for the continued collaboration with our Cuban colleagues, despite some ongoing obstacles at the federal level. And we want to be clear that we will continue this really important collaboration in the years ahead as we move forward. I'd also like to thank the planning team for today's webinar, including Peter Orris, Allison Lofthouse, Gail Reed, Tanya Aguilar, Keith Pratica. I'd also like to give a special thanks to today's speakers, Drs. Pedro Mora, Yadira Olivia Nadars, Allison Arwadi, and Ngazi Aziki, all of whom are great public health champions. And it's through this joint dialogue across countries that we learn so much and make sure our public health are enhanced. And that's why this webinar is really important. I also just want to thank Sylvia Escargo and Sandra Tapia for providing translation today. And special thanks to Mike Yen for helping with the IT support. And with that, again, thank you for participating in today's webinar. And I'll turn things back over to Dr. Orris.
Thank you, Wayne. Next, Dr. Pastor Castel Florit, who's director of the National School of Public Health under the Ministry of Public Health in Cuba. Pastor, sir.
Good afternoon, everyone. It's an honor to welcome you to the Cuban Forum in this collaboration with Chicago and Havana. Thank you to all the participants. The forum will allow us to know the experiences in the fight against COVID-19, the impact of the academic, in the same way that the main barriers that we had faced and we still facing. The pandemic represents one of the most difficult problems that we've been facing. I'm sorry, I couldn't hear well. We have 87.7% of the total population vaccinated, and 40.6% of Cubans have both doses. In Havana is one of the provinces with more vaccinations. This is going to be thanks to the possibility that we've been having of making our own vaccines. The only country, thanks to the fundamental health, to give the priority to health and the process of vaccination and the high participation of the technological sector. Despite the cases that we have, the main cause, I apologize, it's difficult to hear him. To continue with low rates of mortality. However, the access to vaccines in many regions of the world is unequal. Especially worrisome, concerning is the situation of low-income countries where they hardly 7% of the population has received at least one doses of any kind of vaccine against COVID-19. In Latin America and the Caribbean, our region, the consequences, social and economic consequences has been devastating. A recent research estimates that in 2020, 22 million people more fell in poverty with an important impact. And it highlights that the most unequal region in the world is highly affected, and also with infection and mortality of COVID-19. This is concerning for everyone. We have to be more equitative in the health and more global cooperation. In this sense, I'm sure that our exchanges will facilitate the path for future vaccinations. I would like to thank the medical review for the coordination of this forum and for their collaboration. Thank you so much to all the participants.
Thank you, Dr. Pastor. Now I would like to introduce Ms. Gail Reed, the executive editor of Medic Review, that has been so critical to the development of our interchange between US and Cuba. Gail?
Thank you, Peter. Once again, welcome to everyone to this online forum on behalf of our journal, Medic Review, where you can also find current research and perspectives on the pandemic from Cuba and from other Latin American and Caribbean authors. I want to offer you some comparative data. I'm hoping we can put that slide up, the next slide. Yes, I'm hoping you can see it. That will help situate our participants in the realities of both Chicago and Havana. As you can see, there are quite a few similarities and some rather stunning differences between the two contexts. If you look at population for Illinois and Cuba, for Chicago and Havana, they are not quite, they're not very different. But when you get to per capita income, they are quite different. In Havana being about 1/10 of the per capita income in Illinois. Older adults, while it's measured differently, you see more older adults in Cuba as Latin America's fastest aging society. And in Chicago and Havana, you see a similar number of hospitals with more physicians in Havana. When it comes to community clinics, and I needed to add a caveat here, we see 160 in Chicago and 82 in Havana, with some 3,000 family doctors' offices as well. But the 160 in Chicago, of course, are the only the federally qualified health centers. Unfortunately, because of the fragmentation that we suffer in the US, the private clinics, Peter and I both tried to add up this number and it was impossible to find. Now, interestingly, the main causes of death are quite similar, especially the first 3 or 4. And I think that's surprising to many people in the States who would expect infectious diseases to be up there higher in Cuba. But if you know anything about the health system, you realize also that then the chronic diseases are the much bigger morbidity and mortality rates. Finally, and this is infant mortality prior to the COVID situation, you'll see that in both Havana and Chicago, the rates of infant mortality are higher than the larger geographic area concerned. In other words, Chicago is higher than Illinois, Havana is higher than all of Cuba. So these are just some of the data. Obviously, there is much more, but perhaps this gives you a bit of a feeling. And before closing, I want to thank our co-sponsors once again, especially the University of Illinois, Chicago, and the National School of Public Health in Havana, and mention that this webinar is part of a medic review series on various COVID-related topics that are jointly organized with several US universities, health systems, and organizations. So if you're interested in organizing a webinar for your institution with us, just write me at the email at the bottom of this slide. And thank you so much once again for joining us today.
Thank you very much, Gail. And let me add, while we're still thanking our collaborators, we really appreciate the hosting by PAHO, Dr. Mora, in Havana, and the aid that PAHO has given us for this webinar. And additionally, wanted to thank Dr. Ochoa from the Alliance of Public Health Associations of the Americas for their aid in publicizing this event, etc. Now, let me turn to, I'm sorry, I don't, before I turn here, I really want to tell the speakers how flattered we are that you have taken out of your very busy schedules the time to reflect on this and participate in this interaction. If we have time at the end, we will give you time to question each other. And we will also take questions from the group as a whole, depending on time at the end. So we're very, as I said, flattered to have you. You are our leaders in this, and you have the toughest job of public health people around the world, and that is under the pressure of time and the lack of full knowledge and the lack of full data. You had to come up with public health preventive interventions and mitigations, and we salute you for your efforts over the last 2 years, both in Cuba and the US. So I would like to turn it over to Dr. Pedro Maspamejo, and for the national perspective from the Ministry of Public Health in Havana. Pedro, the podium is yours.
Thank you so much. I would like to say hello to the sponsors for this initiative and for this wonderful exchange that we're going to have this afternoon. It's a great opportunity to share experiences amongst our countries as what we've been trying to do for so long. Thank you so much. To start with, I would like to, after the situation that we've been seeing with the COVID in the last 2 years, the disease started in Cuba March 11. Thank you. Here you can see the development of the disease in Cuba in March 11, 2020. We had go in the country until the last
So for the first year, it was a very complex year for us, but we were able to keep under control the pandemic. A question that I would like to actually talk about, because it is something important that is we're going to be talking about, despite the blockade effects, which was intensely felt in this period, to be able to acquire medications and materials for the diagnostic test and other kinds of things that we need in our health system. Well, it was very difficult. It was something that cost the country to make a huge effort to be able to use its own resources to deal with this. So the first year, it was a very complex year, but at the same time, so, you know, it was not as bad as what has been happening lately. So here you can see the confirmed active and diseased cases, and you can see the red line. Despite the active cases, we had a mortality that was very low. One of the lowest rates in the whole continent and even beyond that. And after the second curve that you see on the second spike this year at the end of last year was due to Omicron, and it has been a variant that due to the high vaccination rates, it has not had an effect or a very difficult effect as we suffered with the Delta variant. So in 15 minutes, I cannot really say much. It's very difficult to say a lot of things. So I'm going to be summarizing. But what I'm going to be showing you, how we were able to do our work. Next slide, please. And here, one of the things that the government decided was, in order to lead with this very complex situation, we thought that the actions should be in terms of preventative care for the entire population. So you have the diagram here. I'm not going to go into detail, but we wanted the healthy population not to get sick, and that the confirmed cases would not be serious, and that critical patients would not be dying, and that convalescent population would not suffer the sequela. So you have, I'm not going to go into detail, but you can see the medication that was used, the strategies that we used in each one of the moments. And I'm sure that it was, all of these actions were very meaningful in the development of our pandemic response. Next slide. So one of the things that we did when the pandemic began was that the molecular immunology lab network, we completed this network. And this was an important response. We only had 3 labs in Cuba that were able to do tests, PCR tests in real time. And with this network during the pandemic, and with all the complications that we talked about, the blockade and the economic situation in Cuba because of the difficulties and the difficulties posed by the pandemic, well, despite all of that, we were able to complete a network of molecular labs, and we have 27 labs throughout the provinces in the country. So that's how we were able to provide a better response in terms of the localities and what was happening in the different places. And Dr. Oliveira is going to be talking about this more in depth. Next, please. See here, you can see it talks about, well, there is an article that has been published in the American Journal of Public Health, in December of last year. And you can see here the comparison between the US and Cuba in terms of new daily COVID-19 PCR test per 1,000 persons at 4 time points. So because of the labs, we were able to actually provide and make more tests. We haven't had any problem with these labs, but the network allowed us to have in July 1st of 2021, 3.18 in comparison to the US, which was 1.90. So next slide. So I'm going to be talking about the battle that Cuba fought against COVID. And I always say that the vaccination or the vaccine is very important, but the health system is even more important to deal with the pandemic. So we have our own vaccines, and we have been able to then vaccine 9,801,110 doses, people who have been vaccinated. So completely vaccinated 87.6% of the population, and boosted 42.6% of the population. And you can see how the efficacy of the Soberana vaccine, which is the one that has been used the most, it has a high rate of efficacy and efficiency, both, even though I did not write that down there. So in terms of diseases, so this has been a national effort. The president of the country since the very beginning requested the centers that were producing the vaccine. And next slide, please. And one thing that helped us a lot is the vaccination rate and the vaccination speed rate. And in the global context, you can see here how it happened. The vaccination rate versus the Human Development Index. There are many developed countries that had a lower speed than we do. We have had a high speed of vaccination in Cuba thanks to having our own vaccine. Next, please. You can see here how Cuba is the country that has administered more doses per people, per 100 people. So this is these are the numbers. And despite the fact that these numbers are not taken into consideration by others, I mean, we do have the results and we can show the results. And you can see a comparison from next, please. It's a comparison between December 13 of 2020 and November 8th and 2021. And you can see in blue, that's when the US started to vaccinate people before us in December 13, and we began doing it later on. And you can see the red line and how we're able to actually vaccinate more people. So we're able to have high indices of vaccination, as I had mentioned, and it was as it was mentioned before. And we have, I also can, the numbers also show that. But to conclude, here you see the comparative rates of, next please, of cases and diseases by COVID-19. You can see the accumulated cases and the disease. In Cuba, we have an excess of diseases per 1,000 inhabitants. In Cuban is 109.32, whereas in the US is 262.46. Next, please. So now I'm going to be talking about the role of the government and health stakeholders during the pandemic. And the most important thing is the government directorate and our president, how actions taken by them and the responses of the national health system and all the actions that were taken, all the attention that was given to the situation, to the epidemiological situation, and thanks to the primary, secondary, and tertiary healthcare actions were very crucial. Next. So the key factors involved, and this is not by me, a group that is working in research at this moment about COVID came up with this. These are the key factors: community intervention, intersectoral collaboration, active participation of socioeconomic sectors, the characteristics of the Cuban public health system. They are not in the order they should be, but anyways, the political will and scientific and epidemiological approach. And this is very clear. So what are the challenges? Next, please. What are the challenges of the pandemic for the health system? Next, please. No, the previous one, the characteristics, the epidemiological and clinical characteristics of the COVID-19 pandemic. Well, the control of the epidemic is a challenge, especially because of the implementation of unusual and extensive prevention and control measures that are difficult because of our own culture. So it's difficult to implement them effectively. The vaccine helped. Next, please. Among the challenges also, and it was very difficult for us, the circulation of the variant Delta in July to September of 2021, it was tremendous. And there was a saturation of the health system. And also a very complex situation with this variant, but we're already vaccinating people. And we're going to be showing this later on. So low effectiveness of movement restriction is very difficult to achieve it in our society. There were also difficulties with transportation, people's movement, and that also impacted, but also the population's perception of risk due to the prolonged duration of the epidemic. So we're going to be talking about that later on as well. And next, please. And I can say that Cuba's epidemic response strategy in Cuba was designed using the universal character of the health system and a strong primary care network for the isolation of confirmed cases and the tracing of contacts and suspects, and the early inclusion of researchers and scientific institutions. And when I talk about scientific institutions, I'm talking about the institutions of first level, like the molecular immunology center, the genetics center, the biology center, the Institute of Tropical Medicine, all the centers that were involved in the production of the vaccine. And they were working on this since the very beginning. And this was crucial in our response. So I'm going to end here. Thank you so much for your attention. And we're going to be answering your questions if you have any. Thank you. Next.
Thank you very much, Dr. Miles. And we'll turn now to Dr. Ezike, the director of the Illinois Department of Public Health, for a comparable view, not a national view, but a state view of the last 2 years. And thank you for being with us.
Thank you so much for having me, and I am so grateful to have this exchange, and really already just in the few comments that we've already heard, have learned so much. And so it's very humbly that I continue to listen and learn, because it is clear that it's really not just about money. Can have money and still not get, better health outcomes. And so I am eager to learn about how people in Cuba were able to vaccinate so many people in a shorter amount of time, how to encourage people to cooperate with the contact tracing and the isolation. So I am so eager to learn as much as I'm happy to share what we have tried to do and some of our challenges. Next slide, please. So as you can see here, we have had many cases, over 2.7 million cases, which does not even include those individuals who have found out about their positive status via home tests, and those home tests number quite a few. So of what we have recorded in our state database, we're looking at over 2.7 million cases. Currently, our test positivity is about 15%, the case positivity at 11%. We did reach a peak of about 19 to 20%. We haven't had a lack of testing. We have had nearly 50 million tests performed and reported to us, again, not counting many of the home tests that have become very prevalent. Unfortunately, we have lost almost over 30,000 on the most recent count, over 30,000 of our Illinoisans to this horrible virus. And while our mortality rate in the state of Illinois is much lower than the national average, we still do know that there's opportunity to improve as we encourage more people to vaccinate and take advantage of the other treatment strategies, secondary and tertiary prevention strategies. Next slide, please. So when we think about our vulnerable populations in the state of Illinois, there are many different designations to that. We have people who are more vulnerable based on their constant exposure to the virus, and that might include people in certain job types. Then we might have people who, by their intrinsic personal characteristics, are high risk. That when should they contract the infection, they are likely or more likely to have a serious outcome, as could be predicted maybe by their age or those pre-existing conditions. We also know that just by virtue of people's economic situation, access to care, that their social vulnerability index might put them in a situation where they are more likely to have higher exposure and also a worse outcome should they be infected. So trying to identify all of these populations, and it looks like many different ways in the large state with this very varied population. So whether it's in more rural communities where there's less access to the community health centers or hospitals, or even in places that have lots of hospitals and healthcare providers, but the individuals in those communities maybe are uninsured or underinsured, all of those create additional challenges that create these vulnerable populations that we don't want to forget. Next slide, please. So in terms of our overall health infrastructure overview, we have one central public health agency, and then we have 102 counties, and there are 97 different independent local health departments that care for people over the 102 counties. And so they are not direct, they're not directly controlled by the state health department, but there is intense collaboration, and we do at the state level offer funding, not the entire funding, but we offer some funding to the local health departments. Some of the local health departments also provide clinical care, such as treatment for sexually transmitted infection, diagnosis and treatment, tuberculosis. But again, they're all funded a little bit differently depending on their local jurisdiction in their county. We do have 7 regional health offices that are run by the state with staff in those offices. We have divided our regional divisions differently for COVID and created 11 regions across the state for the COVID-19 response. In terms of bed availability, we have over 30,000 medical surgical beds and about 3,000 ICU beds for our highest and most critical health needs. Next slide, please. In terms of our federally qualified health centers, which was mentioned briefly by Ms. Reed, we do have over 150 federally qualified health centers, and these are nonprofit entities that are focused on primary care, dealing with primary and preventive care. They are supported by the federal government. They're required to accept all patients, regardless of insurance or under insurance, and provide a sliding scale of treatment that people pay based on how much they have, based on their ability to pay. And of course, there are also community-based organizations, which can include social service organizations, civic organizations, other grassroots organizations that also provide services to the people in the state. Next slide, please. So in terms of the public health measures that have been taking, very important that we have to start with education. As I look at the much higher vaccination rate that Cuba enjoys, that underscores the importance of being able to educate all communities, including minority communities, on what is important and why vaccines are so important and what benefits they offer. As well as the education on vaccination, we have to make sure that there is that access to testing and that people understand the importance of early testing so that they can then isolate and quarantine. So also educating people on the importance of isolation and quarantine, and not just that, oh, one has to isolate, but also to provide resources for those who may in fact do the test and find out they're positive and want to be able to isolate and not transfer the infection to many others, but maybe have a situation where they live with a spouse or a partner and they have maybe multiple children, maybe the parents are in the home. And so being able to provide resources where people can have an alternate option, a safer option of where they can isolate to be able to safely isolate and not instead spread the infection to a large household of people, including some vulnerable people in that household. Also want to be able to provide resources like food. If people, there are many people that once they have to take time off for a medical condition, their money is affected. They are not paid if they don't go to work. And so when people have to make the choice between doing the right public health intervention or strategy in terms of isolating, or decide that they isolate or they can't feed their family, those are false choices. And so being able to create supports and resources so that people can do the right thing and not have their family go hungry or not risk losing their home are important things that we'll try to offer during this pandemic. Other things that have been important, we realize that sometimes people can't get to the resources that are available. And so when people can't get to the help that they need, we have to take the help that's needed to the people. And so we had a Wellness on Wheels mobile unit. This is a giant van that can move to the community, that can go into rural areas, that can go into those hard to reach areas and provide the testing or provide the vaccine for people who might have a hard time to get it otherwise. We have had a great partnership with our pharmacies, our retail pharmacies. We have seen that for every age group, the seniors, the young adults, even the children, the majority of those vaccinations have taken place in the retail pharmacies throughout the state. So again, this large scale effort to fight against COVID has combined the public health agencies with so many partners across the state, and that we've needed every single one of those partners even to get where we are. We have had the mass vaccination sites where large numbers of people can go on a single day and queue up and get the vaccine. Some places would require an appointment, some were completely open to walk in, and placing those in popular locations that can easily be accessed by public transportation. One popular site was at the United Center. That's a major sports venue where our world famous Chicago Bulls would play their matches. And so having those strategically located mass vaccination sites was another way to get more of the population vaccinated. As well, we had to have pop-up vaccination sites. Pop-up vaccination sites meant that there was a place where you might set up a vaccination clinic, maybe just for 3 days, maybe for this weekend only, Friday, Saturday, Sunday. You would have the ability to come to a specific place where community leaders have said, we will help get people to this event. Come and bring the vaccine and the people who will administer the vaccine, and we will bring the people. And so again, grassroots events working with community leaders to bring the vaccine and the people to the same place to get these vaccines. So again, it has been not a one size fit all, but all different kinds of solutions and strategies, to get the resources and get the vaccines to the people. Next slide, please. So in terms of our public health policy for primary prevention, at the start, March 2020, that is when essentially the whole state was under a stay-at-home order from March 2020. And then slowly, things began to open. And as things were opening, we were having different limits for groups to gather, and we were promoting mask wearing and physical distancing. There was no enforcement. We didn't really have any public health officers, stationed around the state, making sure that people were wearing their mask or issuing a ticket. So we needed the buy-in and the support of the people. And of course, that was variable in various communities. in terms of the initial vaccination efforts, at the very beginning, the vaccinations were in very limited quantities. And so there was a prioritization scheme to figure out, for these few vaccines that we have at the start, who should those go to first? And so coming up with, starting with our seniors, who our experience had taught us were the most vulnerable, and those seniors specifically in the long-term care facilities, in the homes, were our most vulnerable, that we started there, as well as making sure that our healthcare infrastructure was protected by vaccinating all the people associated with the hospitals, so that we could have and maintain that healthcare workforce for the people throughout this. And then we've moved into, vaccine mandates, and that has turned into this very lively debate between what your responsibility is as a member of a community versus personal freedoms, and how those interact. And I'm sure you've followed some of those debates and discussions that we've had here. In terms of secondary prevention, we had to, we know that we have to identify quickly, those who are infected, so that we can isolate those individuals. And so screening in schools became something very critical to allow us to keep the schools as a safe place and try to maintain in-person learning, because the time that the schools were closed created new unintended consequences for children all across the state. But we also know that there's unequal resources across schools, where there are schools that have the ability to do testing and maintain a safe environment, and schools that don't intrinsically have those resources, and then making sure that that we try to curb those disparities between kids from communities of means and communities with less. In terms of tertiary prevention, we ran into the similar situation that we had encountered with the beginning of the vaccine rollout, where we have monoclonal antibodies and some oral therapeutics, but limited quantities. And so trying to figure out how to allocate that equitably, again, focusing on communities that have been disproportionately affected by the pandemic, and make sure that we can get those resources in a timely fashion to those at-risk populations. Next slide, please. So these challenges have been many. Again, this was a new effort for all public health officials compared to any pandemic that we have described in the past, in terms of its size and scope. And so when we were coming up with guidance in terms of which are the essential sectors of business or the economy or of life that should remain open, and which were not, those were difficult questions. And of course, everyone had a different interpretation. In terms of youth sports, that was a very contentious issue, in terms of, we wanted kids to be in school, but sports and extracurricular activities are also a very important of a kid's school life, and trying to balance between, do we prioritize school and put aside those extracurriculars, the sports, versus trying to find that balance. And so those were very challenging questions that we tried to do a very difficult dance to try to incorporate those important needs. And again, all of this was further challenged by the fact that we were learning new information on the go. We thought, oh, the American football, involves lots of kids lining up, on the field together, very close. But with time, we actually learned that those outdoor settings were less of a problem with transmission. And so again, hindsight being 2020, as we moved along, we could adjust guidance based on the additional science that was learned that gave us more information on how to keep these different settings safe and where things could be more permissible. Schools and daycares, another challenging setting when you think about kids who can't be vaccinated versus teachers who might be at high risk from children who can't mask, who are maybe too young to mask, and not a situation where in a school or particularly a daycare where that teacher or that daycare worker is not able to physically distance from a small child that needs their help to be fed or to change diapers, etc. And then we actually got into discussions and actually implementation at various times of these crisis standards of care, where we had to make tough choices when the number of patients that maybe needed a hospital bed outnumbered the actual available beds. And so making very difficult decisions on who would get care, having to restrict or suspend certain non-emergent surgical procedures to be able to save those ICU beds, as well as deflect and redirect staff to take care of COVID patients and other acute emergency patients. Next slide, please. So again, lots of public and political resistance. Unfortunately, the pandemic did become politicized heavily in this country with some of the requests and the loud voices maybe not being as in line with public health strategies. Again, dealing with a new virus where everyone is learning in front of the public health leaders, the medical leaders, the researchers are learning, in the fishbowl where everybody is watching as we are learning and revising our earlier observations and conclusions. And so understanding, natural immunity versus vaccination, but understanding that all of those information are subject to change as new variants with new properties come onto the scene and maybe reverse some of the information that we had because it's not applicable to these newer variants. We definitely saw that.
Dr. Zika, I need to push you ahead. We're rolling onto other people's time.
Okay, no problem. So again, so many challenges. We had mistrust. We had vaccine hesitancy. People were worried that the vaccines came out too soon. So communication has been one of the biggest pieces in managing the pandemic. And so going forward, we know that communication and having trusted messengers are one of the most important pieces as we move into this third year of the pandemic. And I think I can end there. The next slide is just making myself available for questions, which we probably will do at the end of the presentation. Thank you.
Thank you very much. Sorry to push ahead. Let me move now to Havana and Dr. Yadira Oliveira, who is in the director of the epidemiology group responsible for the COVID response for the city of Havana, for the province of Central Havana. Thank you. We don't have a camera.
Thank you so much for the opportunity. So in Havana, like the rest of the country, prepared in the months of January and February. And then in March, in the Havana, we had this first case from China, and the Havana prepared in terms of the borders as well. And also, of course, physicians and nurses got prepared. And we also took into consideration all the labor centers and everything, all the sectors. So as you can see, this is the incidence and mortality due to COVID-19, especially in 2021. And during the first month due to Delta variant. And the spike that you can see there is due to that with the Delta variant. So that produced a number important of cases. Next. So you can see all the municipalities of Cuba and what happened in them. And in the capital, it has a characteristic that a lot of people that working and live in the same, in other municipalities, people work and live there, but I'm sorry, this is what happens in the Havana. So we have a concentration of cases and it's more difficult to also trace cases, but we have held a public system that allowed us to actually track cases. The characteristics is that we have native cases in Havana, and also there is the municipalities with lower population had also lower incidence. Next. So that's the distribution in both years. And most of the cases were in the 19 to 50 years old. And also we had confirmed cases in people less than 18 years old. And also we have people infected 60 years old and older. So we did have, the network of 27 labs were able to track, and also the positivity rate. Next. So that's the incidence rate in pediatric ages. And the spike you can see there in the months of June, July, and August, when we had the Delta case, and the same thing was happening in the provinces. In the month of May, we started to health intervention in several municipalities. And in June 21st, 100% of the people that were already vaccinated, who were able to be vaccinated. And that's why we had a fall in the incidence rate. Next. So we have there our vaccines. We have Universe, it's people vaccinated 98.5%, and the vaccinated with booster amounts to 51.9%. Our kids in pediatric ages, they are not getting the booster yet. They finish their vaccination in the month of November with Soberana 2, and they're going to be doing the booster later on. So we start our boosting in December, and by January 5th, all the population that had finished during the primary vaccination in July were already vaccinated with the booster by January 5th with the vaccine Soberana 0.1, and it was directed to, and we also use the Abdala vaccination for the boost. Next. And that is the relationship of incidence to vaccination coverage. You can see on week 29, when we have the Delta variant present, But as we said, we began the vaccination. First, some municipalities, then we incorporated 3 more. And by July 31st, we had the 15 municipalities all vaccinated among people who were older than 19 years old. And the health system in our country has played a very important role in the primary vaccination, and all the clinics that Havana has intervened in these actions. In Havana, like in the rest of the country, there is a history and there is a tradition with the national program of immunization. So people trust our vaccine, and they also trust our physicians and nurses, especially the family doctors who joined the action, and they contributed for the vaccination in all the different centers and all the different clinics and all the different sites. So now, since we began in the month of May, the first 4 municipalities were able to provide tools and data to the group of scientists in our country to be able to assess things and conclude that our vaccine has had a very high impact against death and great illness. In these 4 municipalities that they had several cases, people did not have to go to, they did not need the ICU, basically. Next. Among the main actions taken in healthcare, daily analysis and evaluation of the epidemiological situation in an intersectoral manner, as it is characterized by our health system in our country, and the level of the municipalities, but also the provinces. We would do an integral analysis of each one of the cases, the clinical screening aimed at searching for cases with symptoms by the APS system, the primary system of healthcare in vulnerable and high-risk areas that had been stratified by epidemiologists. And also at the level of the municipality and the province, the timely analysis and discussion of epidemiological surveys, which is one of the characteristics of our capital in our country. We have to have an analysis and discussion of each one of the cases and find the contacts of that case. So the evaluation and control of compliance with hygienic and sanitary measures in workplaces, it's very important. This was all part of the national health system. They did an inventory, also not only in Havana, but also the rest of the country, of the workplaces and what was happening there, and trying to trace all the contacts to be able to stop the transmission that could be generated because of one case. The immediate and timely action by the APS in the presence of a case in closed institutions and communities. We had to provide quick responses with professionals who would go to the houses and would actually disinfect the houses and would make decisions right there and then with the contacts. And Havana found several centers where people could be sent, and also confirmed cases could be sent to stop the transmission of the illness. Next. Weekly evaluation and comparison of the epidemiological situation by municipalities and health areas, allowing us to have immediate actions in each one of the areas and also at the municipal level. Always using an intersectional perspective to be able to solve whatever is happening, and timely communication between municipalities and health areas, to be able to determine 100% of the contacts that each case has. Always, it could be more than 22, 14, 15, 22 contacts at the level of the community. So we had to take actions accordingly. Supervision and control teams in events and isolation centers. We went to all the different vulnerable centers. In every defense councils and municipal and provincial temporary groups, they made this. They had discussions about the cases, especially the provincial temporary groups. The governor and the secretary of Havana were present in the debates daily of what had to be done, and daily, our president, also at the country level, would do an analysis of everything that was happening daily. Next. Well, final considerations. As I was saying, the incidence of confirmed cases of COVID-19 showed a notable increase after the entry of the Delta variant, with a predominance of native cases. The highest transmission occurred in the most densely populated municipalities. There was a large increase of cases in the pediatric age group from week 28 to 36, coinciding with the appearance of Delta, and the country decided that they were not going to start the schools until our kids, the younger kids, younger than 18 years old, had been fully vaccinated. And that began in November. The school began in November for the kids younger than 18. And then that was also followed by actions taken for the 1 to 9 age group. Cuban vaccines were effective in controlling transmission. You saw the graphics, and there was a fall. In September, October, it came down, the incidence of cases, and of course, with that translation on number of diseases and grave illnesses. Next. Well, that's all. Thank you so much for this opportunity.
Thank you very much. And to all, now we go to Dr. Allison Owati, the director of the Chicago Department of Public Health. Thank you, Dr. Owati.
Thank you, Dr. Orris. And I just wanted to say this has been really interesting. Even that last comment about schools, how differently different cities, different countries have made decisions in this pandemic. And I think that this kind of exchange and conversation is really critical. I also just wanted to note, as someone who has worked my whole career in public health, I have long been really interested in Cuba. I was supposed to do a rotation back when I was in medical school and public health school, and then with political issues, I wasn't able to do it. I have visited, but I remain really interested in particularly a lot of the primary care and public health work, and I appreciate everybody who worked to pull this together. Next slide. So we already got some background on the city of Chicago, 2.7 million residents, so about 600,000 more than the city of Havana. And you can't talk about COVID in Chicago without talking about race and ethnicity. So about a third of Chicagoans identify as being non-Hispanic white, about a third, 30% non-Hispanic Black, about a third Hispanic or Latino, and then about 7% is Asian or Pacific Islander. And one of Chicago's legacies is that we have 77 community areas and a long history of a lot of neighborhood segregation by race ethnicity. So on the right, these are the zones in terms of how we divide up the city when we're planning. But if you look at the north central area, that is a very heavily non-Hispanic white area. If you look at the far south area or the near south area, that is a more heavily non-Hispanic Black area. And so we talk about race and all of the ways in which people have had different access to opportunities. There's been systemic racism, very different income levels, et cetera. And so even before COVID, the health department in Chicago had set as our goal to work on the city's existing racial life expectancy gap, by which we mean that even prior to COVID in Chicago, Black Chicagoans lived 9 years less long than Chicagoans from other backgrounds. And for time, I'm not going to get into the background, but it's important that you're hearing that. The biggest driver of that gap are those chronic diseases that we started off on, right? Very different when people are diagnosed with heart disease or diabetes or cancer. What happens in terms of what are some of the things that drive different rates of that, different rates of access, different rates of insurance, all of these things. So next slide. Just to give a very quick high level, we've all seen different surges at different points, but I wanted, these are just cases in Chicago, and I wanted to highlight that very first surge that we all had back, April to July, these are diagnosed cases. So while testing was still getting going, we knew cases were on the relatively smaller side. Things were pretty good over the summer. And then we had a big surge last winter, as I know people did around the world. And then in 2021, it was all about the variants. We had a relatively well-controlled Alpha surge in April. We had a Delta surge kind of in the September range. And then we are just now, thankfully, coming down off this Omicron surge. Next slide. And we've done a lot of things at different points in terms of trying to use the data locally to make decisions to balance the very real economic needs and indirect consequences of COVID with the direct fact that many, many people are being hospitalized and dying with COVID and the need to sort of mitigate that. And so I'm not going to walk through every bit of this, but just to kind of give you a flavor. Back in March of 2020, like most of the world, stay-at-home order at the city, at the state, and that is more or less in place for about 3 months. And then over the summer of 2020, we're sort of experimenting with opening things up gradually and making decisions around when can we have different capacities, what needs to happen in terms of masks. And then what happened was, by October of 2020, things were seeming relatively calm. And we actually, for the first time, did kind of a full reopening of indoor dining, for example. There's still masks in place, but people could dine indoors. And then within a month, we started seeing that winter surge and had to close again. And a lot of the early part of the pandemic for people was here, and I think around the world, marked by a lot of uncertainty in terms of where was COVID going, what is our responsibility as a city or as a health department to make really difficult economic decisions. Once we got through that, the winter, we again started with reopening in a limited way, and then the big thing that happens, of course, is December 2020, we start vaccine distribution, and the whole thing changes in terms of, as you can get more people vaccinated, and those vaccines protect so well against severe hospitalization and death, we were able to more carefully sort of expand and think about what options people may have if they are vaccinated as not. So once a vaccine was available, we were doing much more, instead of saying we're going to not allow large outdoor events. We were doing more with saying, we'll have large outdoor events, but you need to show proof of vaccination or a negative test to get into it. And then masking is something that, you know, I know you don't know the whole national context, but both Illinois and Chicago have been more conservative than most of the country in terms of when we were seeing cases surge and hitting levels as determined by the CDC, our national public health organization, requiring masks in indoor settings. And so you can see, for example, June 2021 is when we sort of fully reopened in terms of not having additional restrictions, but there were masks, advisories, and mandates in place after that. And actually, since June of 2021, there have not been any required limitations on activities in the city of Chicago. And I know this is different than most places around the world. So we have not had to, or we have not needed to close things. We have not needed to shut things down again. But the thing we follow are the metrics around, are people getting hospitalized? Are people dying? Is there a threat to our healthcare system? And we were very close with this Omicron surge to potentially needing to do some of those more dramatic actions again. But instead, the first thing we did was start requiring proof of vaccination for high-risk indoor spaces, restaurants, bars, large gatherings, et cetera. And so that's just high level, some of how we've responded. And I recognize that is probably different. Next slide.
I need to slow you down just a bit.
Oh, okay, sorry.
I may push you at the end, but right
No
now.
worries. No worries.
Thank you.
Yeah. So this is just a comparison of how differently cases, hospitalizations, and deaths have shown up here in Chicago throughout the whole pandemic. So on the left of each of these, in blue, yellow, and red, these are on different axes, but you see that cases were relatively low because there was not very much testing for people who were not seriously ill, but hospitalizations were high and deaths were very high. In that next surge, that was happening just as vaccines started to become available. Most people still could not access a vaccine during that winter surge last winter. And you see, you know, we've put these on to have them all be at the same level in terms of cases, hospitalizations, and deaths. But since then, look at on the right side, you see the very high cases where we're now doing a lot of testing, 60,000 tests a day just in the city of Chicago, not including all of the home tests, which are about twice as many again. But you see hospitalizations are high, but nowhere near as high as what we had seen when cases were previously high. And then deaths have stayed much lower. Go ahead, next slide. And so we use a publicly facing data dashboard that gets updated every weekday. And this has become a site that gets millions of visitors to it. And this is the same data that we use to make decisions around mitigation. When can we reopen? Is it okay to have schools? What else needs to happen? And a lot of our focus has been on taking our local situation and turning that into risk levels and making sure that people understand. So this is pulled from just yesterday, and you can see we're coming down off of that Omicron wave and numbers are looking much better. I did want to highlight, though, on deaths there in the right, we're currently averaging 19 Chicago residents dying every day from COVID. And we've had a cumulative of more than 7,000 Chicago residents die from COVID. And to put that in some perspective for you, that's actually, when I looked it up, there were only about 8,400 deaths in all of Cuba from COVID-19, as reported to WHO. So just in the city of Chicago, we've had 7,000 deaths. And importantly, Chicago has had many fewer deaths per capita than most other cities, just as Illinois has done better than most of the country. And so in the United States, 1 in about 380 Americans has died of COVID. In Cuba, when I looked it up, it's about 1 in 3,500 have died from COVID. And there are places, you know, in the US that are really, you know, in New York City, 1 in 222 New Yorkers have died of COVID. And so we do not take lightly the need to make sure that people can access vaccine, because it is by far the most important thing that helps protect them from death. But we have seen, my sense is different than in Cuba, a lot of people very hesitant to get vaccinated. Next slide. And so this is our Chicago COVID-19 vaccine uptake over time. And I actually have shown this on the left by race ethnicity, because remember I said at the beginning, we continue to see Black Chicagoans. We have this large life expectancy gap prior to COVID. And unfortunately in purple there, you can see that only about 60% of Black Chicagoans have had a COVID vaccine in Chicago, whereas over 80% of Asian Chicagoans have, for example. And we have really tried to adjust our efforts to focus on the community areas and the trusted voices in any part of the city that needs to work on this. Next slide. And so we've used other things like travel advisories, where again, we've used data to help Chicagoans make decisions about where in the country may be higher and lower risk. And you know, lots of examples of using data that we could talk about, but I know time is short. Next slide. We did something when vaccines became available that is very unusual. Instead of just making vaccines available by age or by type of worker, we identified 15 community areas in Chicago, which are the ones shaded in blue, that we knew were at very high risk for bad COVID outcomes, because they had not a lot of primary care connection, low insurance, lots of chronic disease, lots of workers in jobs that they could not work from home, high COVID rates. And we actually said, people who live in these communities get vaccine first. And this idea of equity not just being a part of our strategy, but being our strategy has been, I think, one of the real learning points. There's lots of work to do here. We have certainly not gotten everything right, but saying where resources are scarce, they must go where they are most needed has been what we've used to drive every decision. Next slide. And so our response has really tried to be community-led. We do not have the strong network of community health workers that I know you have in Cuba and the primary care providers in these blocks. So we had to stand up a new core of Chicagoans who were diverse, and we did a Earn as You Learn program. And all of these folks, of the 801 Chicagoans who have been hired, 63% of them are Black, which is important, where that is the group that we're most wanting to build confidence in. And all of these folks had never almost all of them had never worked in public health, but have through COVID learn to do contact tracing, learn to do response, door knocking, vaccine ambassadors. And we've built this new and flexible workforce from the most impacted communities. And that's been part of any success that we've had. Next slide. And so we really, in our vaccination outwork, have worked to try to prioritize access and equitable distribution. So for example, you will probably find it interesting. We have a program here. Anybody in the city of Chicago, we will bring a vaccine to your house free of charge at a time that is good for you. And we will give an incentive of $50 per vaccine for your time and effort to do this. And we do that for boosters. We do that for all ages. It's been a very successful program for us, and it's where we put a lot of efforts in addition to the mass vaccination, et cetera. We've done other things like prioritize ticket access for people who are vaccinated, doing lots and lots of door knocking and signing people up. Next slide. The biggest challenge that remains is that there are still a lot of Chicagoans who have not chosen to be vaccinated, and we do not have a lot of vaccine requirements different than you may have in place there. And so this just shows during our most recent Omicron surge, you see these show kind of over September, October, November. In red is what happened to unvaccinated Chicagoans. And on the left is hospitalizations, and on the right is deaths. And so you see that in the blue lines, these are Chicagoans who are vaccinated and boosted. Deaths on the right there stayed almost flat, but this huge increase still continues to land on unvaccinated Chicagoans. And unvaccinated Chicagoans 5 to 7 times just during Omicron, more likely to be hospitalized or die. Last slide. We are very focused in terms of our geography. As I said at the beginning, this remains a city that does not have equal opportunity depending where people live. And so this is just showing in blue our community areas where we have high vaccination and low death and hospitalization rates. And in orange are communities where we have low vaccination and high death and hospitalization rates. And so we're doing a lot of geographic focus. Last slide. Is just that the ongoing challenge, I think, in the US, and one of the big public health messages to learn from Cuba and others, is that we have so much trouble with health inequities, where we do not consider, in our system, it to be a right for people to be able to access care. The number one independent risk factor of whether someone is vaccinated in the US, in Chicago, is whether they have health insurance. And that is a problem. And that is something that is going to be a problem for everybody who cares about public health in Chicago and across the US. And I, again, really appreciate the opportunity to share lessons learned.
Well, thank you very much, Dr. Awadi. And I think this has been a very interesting time, but it's like any good novella or short series. The first episode should really hook you. And I have many more questions now than I had at the beginning. And there are many interesting comparisons here. Unfortunately, I will be frustrated as the people who've been posting questions on the Q&A, which are also very interesting, and perhaps we can get to some of them by email afterwards, but we're really out of time. I wanted to make sure that we emphasized Alison Loftus' role for the global program in making sure that this happened, and organizing it, putting it together, and keeping us on track to get this done. And then also the dean and the director in Havana that struggling through keeping this communication avenue open despite problems in doing so. So thank you all. And I'm very happy that you spent time with us today. I would underline again, Medic Reviews offered to put together other interactions and other exchanges that maybe we'll be able to get to some of the questions that certainly I have, and many others, I'm sure. Thank you again, everybody, for attending.